Good evening and welcome to our show, Women to Women. I'm Carol Paz, your hostess, and as we always promise, we have a very special guest with us tonight. But before I introduce her to our listening audience and our other guests, I'd like to thank our sponsors, Carpa Nevada LLC, importer of fine Portuguese olive oil, aged balsamic vinegar, and international health teas, as well as Villa Basque, Dalian Cafe, home of Pete's famous Basque delicious chorizo, right here in Carson City. And by the way, this evening, all of our guests are receiving this 25-year-old aged balsamic from Modena, Italy. So let's get on with our show, and I'd like to welcome Dr. Amy Hayes. Amy, thank you so much for being with us.
Thanks for having me.
Amy, before we get started, I usually have time to just say, I'd love to know where you're from, and I would love to know what brought you into the field of medicine, in particular, OBGYN.
I actually grew up in South Tahoe.
Okay.
And took a circuitous route to get back here, but eventually ended up on the other side of the Sierras. And medicine, I grew up with 12 cats. And they brought in a lot of little victims to patch up. And so originally thought I was going to do veterinary medicine, but decided people were easier to take care of. I didn't have to deal with their owners.
All right.
Which is why I didn't do pediatrics.
Okay.
And OB and GYN just gave me the opportunity to take care of women through their whole life. And I was impressed by how open women were to really taking care of themselves when they were pregnant.
And I think you're making a statement that is maybe more true today than it was 50 years ago or even 25 years ago, that women are very open to wanting to have a healthier lifestyle and to take better care of themselves.
Definitely.
Yes.
Yeah, they didn't used to walk in with a pile of things printed off the internet in the past.
That's a challenge for you. And I'd also like to introduce Candace Stewart to you, Amy, who has been on our show before, and Candace is the author of Welcome to Planet Alzheimer's, which is a very popular book in doctors' offices. So, Candace, what's one of the questions, as you're representing the other women here in the Northern Nevada area, that you'd like to ask Dr. Hayes about concerns that we as women have?
One of the questions I have for you is, what is the latest treatment for fibroids? I know for maybe 10, 15 years ago, it was hysterectomy. Is that still the way it goes, or are there other treatments now?
Okay, so uterine fibroids are very common, and what we have found is that the majority of women will have some fibroid during their life in their uterus, which is the fibroids are benign growths of the cells that form the uterus. They just grow in these little tumors. Many of us will observe women and treat symptoms as they come along. If the fibroids are creating pain or heavy bleeding or have grown to a size where they're impinging on other organs, then surgery used to be the only option. Currently, there are some less invasive options. There's uterine artery embolization, which is performed by an interventional radiologist, where a catheter is put into the venous side of the uterine circulation, and tiny little microbeads are put in to block the blood flow to the fibroid. That's one option. A lot of advances have come with the treatment of fibroids surgically too, with minimally invasive surgery, which all of our gynecologists do. You can do several different procedures to try to treat fibroids if women want to maintain their fertility or keep their uterus. You can do a myomectomy where you actually remove the fibroid. There are some other techniques where you can cauterize the area around the fibroid, similarly destroying that circulation to it. Yeah. And then if it does come to surgery, we prefer as a group to approach that either vaginally or with a laparoscopic approach. Very rarely do we do anything open. Unfortunately, in the United States, 50% of abdominal surgery, the hysterectomies are still done abdominally. We do less than 1% here.
Wow.
Yeah, we
Huge
don't.
difference.
We don't have a robot. I have to be clear, but we don't need a robot.
Okay. Now, maybe you can help our audience understand why you're making that remark. Okay, we don't use a robot.
Well, it's rather catty. There is a instrument called a Da Vinci robotic surgical system that two of the hospitals in Reno and one of the hospitals in Tahoe have. and it allows surgeons to perform surgery using the robot to actually do the procedure, and the surgeon is actually playing a video game, essentially using remote controls. There are cases in which using that robot is very useful. Our GYN oncologist in Reno uses one, and I'm very glad he has that. But it's not necessary for all cases. It increases the cost significantly, and the outcomes for routine cases are the same.
Okay.
And then as a group, you know, there are 7 of us, actually there are 9 of us doing surgery, 7 of us taking call. And we all do minimally invasive approach when we can, which is about 98-99% of the time.
Wow.
Okay, I have
that's
a question
amazing.
to insert here. That is a huge difference compared to 25 and 30 years ago. Now, if you have a family history, if it's genetically in your family that you would have fibroids and they have caused some type of uterine cancer, then would you just do a complete hysterectomy?
Fibroids almost never cause cancer.
Okay.
So luckily, we can observe people. And we usually, if we know a woman has fibroids, we keep her under surveillance. We make sure that she doesn't develop rapid growth or severe pain or heavy bleeding that might be an indication that there was a problem. But
Okay.
many women will keep their fibroids, and you don't have to have a surgery for it anymore.
Good, good. Candace, do you have another question you'd like to ask?
I do kind of a follow-up. If you do have a hysterectomy, and there's, again, I'm going back, 10, 15 years, a lot of issues regarding hormone replacement therapy. And so what is your feeling on hormone replacement therapy? I know that a lot of the argument was always that there might have been a connection to breast cancer on hormone replacement therapy. So,
Well, Women's Health Initiative, which ended about 10 years ago, was the first time we had done a double-blinded randomized study, and it was very big, very well designed. And it came out with a lot of information, which at the time we thought was generalizable to the all women. As we've parsed out more information in subsequent studies and re-looking at the data, it's not as black and white as it seemed. Whenever we're doing surgery for a non-cancer, non-malignancy situation in a woman who's premenopausal and we take her ovaries out, we almost always replace her hormones until the natural age of menopause,
okay.
and then encourage them to try to wean off.
Okay.
As far as hormone replacement goes and the connection to breast cancer, it's very difficult. If it were easy, it would have been obvious. The studies would have shown a definite indication that breast cancer increased the incidence. Even the Women's Health Initiative that was using 2 arms, one was an estrogen only, one was an estrogen plus a progestin. In the estrogen only arm, those women have less breast cancer.
Wow.
Now, I can't say that estrogen prevents breast
Right.
cancer, but it doesn't apparently
Cause it.
cause it. Some people will have a hormone that is sensitive to the estrogen, and so if you're taking hormones, it might grow faster. But in that situation, those women are getting health care, they're usually getting mammograms and having exams. Often their tumors are found earlier. So hormone replacement is a gray zone, which is why there's so much conflicting information about it. And I think every patient needs to be taken as an individual. There is no cookbook approach.
Thank you, Candace, very much for your contribution here. And I'm hoping that our viewing audience out there is also gaining lots of information that you may have been wondering about. And I think you're saying, Dr. Amy, that the best thing is to always stay up to date with your OBGYN.
Yeah, there are things are progressing and new data is coming in, and there are a lot of alternative therapies that are being discussed as well.
Okay, so we'll be back in the next portion, and we want to encourage you to stay right with us because we have some more very demanding questions with good answers, I'm sure.
Join us at the Carson Nugget for The Prize is Right, our 3 million point swipe and win giveaway happening every Sunday through Thursday. You can win up to 100,000 points instantly at our kiosk, and all you have to do is swipe. Only at the Carson Nugget.
In business for over 5 years, Play Your Own Music offers music lessons from the best quality music instructors in the area. We also offer band instrument rentals, guitar repair, and we have a recording studio on site. Call us at 885-PLAY.
When a disaster strikes our region, Will you be ready? Learn about sheltering in place. Since each emergency is different, make sure you plan for alternate routes away from your neighborhood. Plan meeting places and long-distance phone numbers if you are separated. Assemble food, water, medicines for at least 3 days, and a portable radio to stay informed. Remember, make a plan, assemble a kit, stay informed, be ready. For more information, contact your local emergency manager.
Hi, I'm Stephen Lincoln with CarsonCityHomes.com, Carson City's original online real estate resource.
At CarsonCityHomes.com, you get effective and easy-to-use tools to help you select your next home today. With our easy-to-use website, you can search listings throughout Northern Nevada and narrow the results by selecting every facet, quirk, and quality you desire. Visit CarsonCityHomes.com. Welcome back to the second portion of our show. We're filming tonight here at Dr. Kent Gabriel in Carson City. We'd like to thank him so much. He's a wonderful plastic surgeon, and his offices have been made available to us. So on this portion, we have Dr. Amy Hayes, who is back with us, local obstetrician gynecologist, and with her we also have Elizabeth Tully, who's going to be asking questions representing all of us women here in the Northern Nevada area. So Elizabeth, welcome back again on our show.
Thank you.
And do you have a
Carol.
question for Dr. Amy?
I do, Dr. Amy. What do you feel are the greatest obstacles to a smooth pregnancy and delivery? Things that women have within their control?
Okay. Well, having a smooth pregnancy starts before you get pregnant, and trying to optimize your health. If you have any health issues, getting those under control, getting rid of bad habits, particularly smoking. The drinking's not usually so hard. The smoking is tougher. I always prefer that women, if they're planning a pregnancy, start their prenatal vitamins and extra folic acid at least a couple months before they conceive, and make sure that they're up to date on, their well care to find any problems before that happens. That's for the 50% of pregnancies that are planned. For the rest of the crew, getting early care, we have a lot of new tests that are available to determine if there are health risks during the pregnancy, particularly for the baby or for the woman. Our prenatal testing has made huge advances in the last few years. So we're now able to offer women a first trimester screen where they can have an early ultrasound that increases the accuracy for screening for Down syndrome and some other issues significantly. We also have some new genetic screening tests where with one tube of blood, they can screen for 103 different genetic carrier states.
Wow.
So if the woman is a carrier for a disease that she didn't know, then we could test the father of the baby and, if necessary, get some genetic counseling set up.
Okay.
There are also other tests for screening for trisomies that are more common in women over 35, but can occur throughout our population that help prevent unnecessary testing like amniocentesis.
Oh, okay. For those of us who may have careers, or those of us out there who may make a decision to wait much later, even early 40s, to have our first child, do we run higher risks for the health of the mother as well as for the child?
Yes, both. Unfortunately, when you're in your early 40s, you have eggs that are in their early 40s. And so the chromatin, the DNA material inside the nucleus of the egg, becomes a little less stable. Part of why having the early testing for those genetic problems is important. And unfortunately, for many women, being in their early 40s, they may have other health issues. They're at an increased risk for diabetes, an increased risk for hypertension, or developing preeclampsia during their pregnancy. But many healthy 40-somethings are able to carry normal pregnancies and have, healthy babies.
Maybe a second or a third pregnancy in the 40s would be a healthier situation than a first-time pregnancy?
Oh, they all carry the same risk.
Okay, all right. Elizabeth, do you have another question?
I do. I have a particular interest in the healing of eating disorders. So my question is, And I guess what I'm thinking about is the bulimic patient, because I think if a woman is obviously compulsively eating and overweight, that's obvious to a doctor, and radically underweight, that's obvious. But the bulimic, it's trickier. So I'm wondering if, and I would think about all kinds of doctors, can you see signs? Can you see the signs of someone who is bulimic? And if you can, what do you do as the OBGYN?
All right, well, it's not my area of expertise. Some of the signs are apparent. Not often things I'm going to pick up on just a routine OB exam, but I do worry if people are having problems with their teeth when they're young, because that's a sign that there's too much acid in their mouth too often. I often talk to women about their body image and just issues of self-esteem, and pay attention to the comments they make. And if I am concerned that I'm getting feedback that doesn't fit, I'll ask if they have problems. And then I often encourage them to, go to see a counselor who specializes in that, or find somebody else they feel comfortable talking to, or if they have a primary care doctor, often send them back there.
So it might be not so much a checkup that would reveal it, but some of the things she would say that might reveal something's awry, and it could make a pregnancy risky? Or?
Well, pregnancy is a really difficult time for people who have suffered from eating disorders. And so it's helpful to know at the beginning of the pregnancy if that's been an issue in the past. I often don't actually make the diagnosis, and often women will share that with me when they come in, and as they start to see their bodies change, gain the weight, sort of lose the control that so often is important with people who like to control their bodies when that's all they can. And
excuse me, I have a very brief but personal experience. As a teacher back in New York, a colleague of mine in her first pregnancy was very concerned about the amount of weight. In fact, her name was Elizabeth. And when she didn't want to gain more than 5 or 6 pounds during her pregnancy. And that little boy was born, but he was in the hospital for the next 5 months after birth, being tended to. And he does have, extenuating complications because of her desire to maintain a very forced weight. And she did go on to have a second pregnancy and a third, but she no longer had that feeling, that mentality in her head to maintain. But that little boy, Christopher, he's adorable, but he has learning disabilities and issues a lot.
goodness.
Yes. So I want to say thank you so much again, Elizabeth, for contributing to this. Dr. Hayes, thank you very much. Now, before we leave, I kind of have a final question. Do you often find yourself, since we're talking about a freedom that women have with their OBGYN, especially if she's a female, young women who come in, who have been, let's say, sexually permissive, and they want to have a child. How do you counsel them in terms of getting them ready for pregnancy if they have been sexually active and maybe with many partners?
Well,
I mean, that's not such an uncommon situation.
No,
As a teacher, I was faced with that a lot.
Yeah.
With girls who confided in me at the high school level.
Well, I start long before they get pregnant with reminding them that they own their sexuality and that they don't owe anybody anything, and that they should be the ones to make a decision when they decide to become sexually active, and they should be very picky. But that's just part of, what we do when we see young women is to try to encourage them to, pay attention to themselves, not be pressured, not put themselves in situations where they won't be able to control that.
Right.
And then, we screen for sexually transmitted diseases. We try to counsel them, make sure they get their HPV vaccines, encourage them to clean up their act, as it were, before they try to conceive.
That's right, that's right. It used to be, abstention was the only answer, but in reality, we're dealing with so many relationships out there, and when a child can be, or a fetus can be the product of that relationship, as a female, you want to try and deliver the very best that you can for a very healthy little person. to come from that pregnancy. So there is a strong note of caution to be very careful, very careful. All right, we're coming back again in a third portion, Dr. Amy, and we want to say thank you so much, Elizabeth, for being with us this evening.
Thank you.
Don't go away. We'll be right back again.
Apex SCF provides cutting-edge, hands-on training that effectively addresses today's threats of violence.
The Apex Stay Alive course teaches proven methods for personal protection and attack countermeasures that can be applied in any environment. In your home, at the workplace, or on campus, Apex will teach you the necessary skills to stay alive, including how to recognize and react to an active shooter scenario.
If you knew you had to fight for your life tomorrow, would you train today? Contact us now to sign up for a class in your region.
When a disaster strikes our region, will you be ready? Learn about sheltering in place. Since each emergency is different, make sure you plan for alternate routes away from your neighborhood. Plan meeting places and long-distance phone numbers if you are separated. Assemble food, water, medicines for at least 3 days, and a portable radio to stay informed. Remember, make a plan, assemble a kit, stay informed, be ready. For more information, contact your local emergency manager.
Football is back! And it's your turn to score with Carson Nuggets touchdown to cash drawings, where you can win up to $50,000. Come down every Friday and Saturday for your chance to win big.
Welcome back to the third and final portion of this show with Dr. Amy Hayes. We also have another very special guest I'll introduce to you in just a moment. But first, I'd like to thank the sponsors for this part of our show. I'd like to thank CarsonNow.org, which is the 24/7 place to go if you want to know what's happening here in Carson City. I'd also like to thank the Nevada Appeal and the Record Courier for their faithful support, and they always encourage us to shop locally, support our small businesses here in Carson City. So let me introduce to you Alicia Idell, who's been with us before. Welcome, Alicia.
Thank you.
Good to have you. And we're going to finish up this segment with some questions that Alicia has that represent all of us women here in Northern Nevada. And Alicia, your first question for Dr. Amy is what?
Yes, Dr. Haynes, families with breast cancer history, is it advisable to advise the families to do the breast cancer tests?
Yeah, whenever we see a patient in the office, we want to get a complete family history. And women who have a history of breast cancer in their family, we would ask more detailed questions. And if they were candidates, there are 2 tests that are offered for the BRCA genes. We call it BRCA1 and BRCA2. But the most important thing is that breast cancer occurs most commonly in women with no family history.
With
Now,
no
that's
family
surprising.
history.
Right.
With no family history.
So everyone needs to be screened for breast cancer. Those patients who have a strong family history of breast and or ovarian cancer should get testing and should certainly discuss it with their providers. But all women are at risk. And so I encourage everyone to do their breast exams after their period and to start their cancer screening at age 40 or 50. The U.S. protective, I can never remember all the details, but the people who make the rules,
Right.
I'm sorry.
That's a good way to put it. Right. We listen to the
It's
rules.
the preventative task force. They've recommended cancer screening starting at age 50, but those of us in practice have difficulty allowing that to go on when we see women in their 40s with early breast cancers that we are catching and preventing and curing by catching them early. So the majority of the health community recommends beginning screening at age 40.
Or age 40.
Yes.
Isn't that too early?
No.
No.
For those women who have breast cancer at 41 or 43, it's not too early. Now, younger women have more dense breasts, so they can be more difficult to screen and more difficult to examine. And so the Preventive Health Task Force's concern was that there were too many biopsies being done for benign disease. I argue that although it may not be cost effective, those women who have those exams and don't have cancer are very relieved. And those women whose cancers are found, their lives are saved.
Yes.
So I'm a rebel on that one.
Okay. You know, when I was going through my breast cancer, and that was nearly 30 years ago, the ratio was 1 out of every 11 women would have breast cancer. Has that ratio changed? Has it improved or gotten worse?
1 in 8.
1 in 8. So it has changed. Okay, it's more common. They're finding it more often now.
Right.
All right. Alicia, yes.
So if the result is positive, what preventative measures would you recommend?
Well, as with many things, maintaining a healthy lifestyle, decreasing the amount of fats in your diet, decreasing your alcohol intake, being active, those are factors you can control. There's a lot of things you can't control.
Will it affect the person who is highly stressful in her life, be so worried about having this gene in her body?
Well, women, if we test women and we know they carry the BRCA gene, then we will change their surveillance. We will change our recommendations. And as Angelina Jolie has made popular, some women will choose to have preventive surgery and actually go through with mastectomies.
And those are simple mastectomies?
I assume.
Okay. Yes.
I don't do those, so
okay.
I leave that to experts.
Right, and I think that Alicia brings up a concern that we women, if we have to go to a breast cancer specialist, that a simple mastectomy for preventive measures is much different to work with afterwards in terms of plastic surgery than a modified Halsted.
Oh,
yes,
the surgery has definitely improved.
Yes, and I think women have much to look forward to in terms of breast reconstruction if they do have a simple mastectomy or they have to have another more invasive piece of surgery. So that's good news on the horizon out there too. Continue. Do you have another question you'd like to ask?
All right, I have another question, Dr. Hicks. Elderly women experience what they call mild urinary incontinence.
Sometimes it's not mild.
And I have a lot of friends who've done the sling mesh surgery. Now,
we don't have too much time, Alicia.
okay.
But your question is good.
Right. So, will the surgeon that does this recommend to abstain any sexual activity with the spouse?
I hope not. That's part of the point.
Okay, how do you mean that?
Well, menopause is different than it was for our grandmothers. Women have different expectations. They want to be active, and that's not only just in their daily lives and their professional lives, but also in their sexual lives. And urinary incontinence and the pelvic relaxation that goes along with that can interfere with all aspects of a woman's life. There are several different approaches to incontinence. The first is to do physical therapy and to try to incorporate some strengthening exercises. Whether or not you're going to have surgery gets you in better shape before you have that surgery, and some women are able to avoid surgery. When it comes time for surgery, we are fortunate in our community, and it's very unique. Our urologists and our gynecologists work side by side. And have a very collegial atmosphere. So we refer patients back and forth to each other, we operate together, we combine our procedures, so women get the best care here in Carson.
Wonderful, wonderful. And I hope that our viewing audience has also benefited from this discussion, sometimes rather frank, sometimes rather general. But I want to say a special thank you to Dr. Amy Hayes. Thank you so much for being with us. And thank you, Alicia, for returning with your questions.
Thank you.
You're welcome.
So we look forward next week to a brand new program. We hope you'll tune in, and you never know what's coming on Women to Women. But have a good evening. Stay well. Good night.